My name is Marcus Mize. I'm a pharmacist at Cape Fear Valley Medical Center in Fayetteville, North Carolina. And today we're going to talk about some of the treatment principles for psoriasis using systemic non-biologic medications. Psoriasis is an autoimmune skin condition that causes rapid turnover of skin cells and leads to the buildup of cells on the surface of the skin, leading to scale formation and red patches that can be itchy, painful, and sometimes even bleed. For some individuals, this condition extends beyond the skin surface, developing into what's known as psoriatic arthritis. This form of arthritis causes swelling, pain, and stiffness in the joints, significantly impacting a person's quality of life. It's a reminder that psoriasis can affect more than just the appearance of a person's skin. It can influence the overall physical health and well-being of those affected. In fact, factors commonly affecting an individual's health-related quality of life are commonly affected by this condition, including increased depression scores and general health status. As a pharmacist, understanding the intricacies of psoriasis and the comprehensive approach needed for its management is crucial. This includes being knowledgeable about the medications available, their mechanism of action, dosing, and the key concepts necessary for effective patient care. Let's dive deeper into these aspects to better support our patients living with psoriasis. The purpose of this video is to educate pharmacists on some of the key medications, mechanism of action, dosing, and key concepts for managing psoriasis. The inflammatory response in psoriasis involves the release of various cytokines, particularly tumor necrosis factor alpha and interleukins. These signaling molecules contribute to the inflammatory cascade, promoting the proliferation of skin cells and the formation of plaques. Treatment approaches for psoriasis aim to slow down the excessive skin cell turnover, reduce inflammation, and manage symptoms. When it comes to treating psoriasis, our main goals of treatment are to improve the appearance and discomfort associated with this condition. Our aim is to minimize flare-ups through a combination of medications and personalized strategies tailored to each patient's needs. Additionally, we keep a close watch for any accompanying health issues such as high blood pressure, high cholesterol, diabetes, or psoriatic arthritis and address them as needed to ensure comprehensive care. Identifying and addressing triggers such as stress, infection, lifestyle factors like smoking and excessive weight are also crucial components of our approach. Throughout all of this, we continuously evaluate the effectiveness of treatment, adjusting our approach as needed based on the severity of the condition, which may involve exploring combinations of therapies to achieve the best results. We also want to keep in mind that psoriasis can have a meaningful impact on a patient's mental health due to various reasons, such as stigma associated with the appearance of their skin. As a result, we want to offer support and resources to help patients cope with any associated depression, anxiety, or other psychological challenges they may face. The goal is to not only improve the physical symptoms of psoriasis, but also to enhance the overall well-being and quality of life for those living with this condition. Treatment options include topical therapies, phototherapy or photochemotherapy, systemic therapies, which would include both biologics and non-biologics, as well as moisturizers, or most commonly, a combination of these treatments. For mild to moderate psoriasis, topical agents are typically first line, followed by the addition of phototherapy. The phototherapy is then replaced by a systemic agent used with or without topical agents if prior therapies were not effective. Moisturizers are used throughout the treatment algorithm to help with preserving skin moisture, minimizing skin shedding, manage scaling, and potentially alleviate itching. For moderate to severe psoriasis, first-line therapy is usually a systemic agent. This can be used in combination with topical agents or phototherapy according to patient-specific factors. The dose of the systemic agent can then be increased appropriately based on the patient's needs. We can also use a combination of systemic agents. If a patient response is still inadequate, a switch can be made to a different systemic agent. And once again, moisturizers are used as needed throughout this process. Although biologic agents have demonstrated more efficacy in the treatment of psoriasis, they come with a higher price tag. Methotrexate has long been a fundamental treatment for moderate to severe psoriasis and psoriatic arthritis, serving effectively in both mono and combination therapies. As a dihydrofolate reductase inhibitor, it slows nucleic acid synthesis and boosts anti-inflammatory adenosine levels. Starting doses range from 10 to 15 milligrams weekly and are adjusted for efficacy and tolerance every 4 to 8 weeks. Despite being less effective than certain biologics, and phototherapy in direct comparison, methotrexate's combination with treatments like etanercept enhances outcomes. Nevertheless, its use necessitates caution, particularly with alcohol intake and in patients with hepatic dysfunction or baseline cytopenia, while avoiding concomitant use with sulfa drugs or acitretin. Common side effects like GI dysfunction and increased infection risk can often be mitigated through dosing adjustments or alternative administration methods. Regular liver function monitoring and folate supplementation are recommended to minimize toxicity and side effects. The risk of hepatotoxicity increases once a patient has received a cumulative dose of methotrexate of at least 1.5 grams, although the risk still occurs at all doses. Dosages may vary, generally not exceeding 30 milligrams per week, with adjustments based on therapeutic response and side effect management, underscoring the importance of adherence to prescribed regimens and monitoring guidelines to ensure safe and effective treatment. Cyclosporin, a potent immunosuppressant, is designed for severe refractory psoriasis types, functioning by inhibiting calcineurin to dampen pro-inflammatory T-cell activation. Its efficacy is dose-dependent, with the effective maintenance dose typically ranging from 1 to 3 milligrams per kilogram per day, divided into 2 doses. The minimum effective dose should be used to minimize adverse effects, including hypertension, nephrotoxicity, and others like hypertrichosis and headache. The maximum recommended daily dose is 4 milligrams per kilogram. Long-term use is discouraged due to safety concerns, emphasizing the necessity for careful dosing, renal function monitoring, and management of adverse effects. Ideally, this medication should not be used for more than 12 weeks at a time. Once stopped, gradual tapering, such as 1 milligram per kilogram per day per week, should be considered to delay relapse. For better results, it's recommended to use cyclosporin with other treatments like UVB light therapy, but these should be done one after the other, not all at once. The medication's interaction profile, notably as a CYP3A4 substrate, requires vigilance for drug-drug interactions, especially with statins, calcium channel blockers, and NSAIDs, to avoid compounded side effects. Acitretin's effectiveness depends on dosage, with lower doses, such as 25 milligrams per day, being better tolerated than higher ones like 50 milligrams per day, though low doses alone are generally not sufficient for treatment. It's often paired with topical treatments like calcipotriol or light therapy to enhance outcomes. The drug can cause side effects such as hypertriglyceridemia, dryness affecting the eyes, nose, mouth, skin, and nails, as well as various other possible ophthalmologic changes. While gastrointestinal issues are uncommon, there is a risk of hepatitis. Acitretin is teratogenic, so it's crucial to avoid use in women who might become pregnant unless stringent birth control measures are in place during treatment and for 2 years afterwards. Alcohol should also be avoided during treatment and for 2 months following completion. This retinoid, recommended for various psoriasis types, works by modulating skin cell turnover and has anti-inflammatory properties, but requires monitoring for liver and lipid changes and careful consideration of drug interactions, especially with oral retinoids and vitamin A. Apremilast, an oral medication targeting phosphodiesterase 4, is used for moderate to severe psoriasis and psoriatic arthritis, working by reducing inflammation and adjusting immune responses, notably IL-10 levels. Starting with a low dose of 10 milligrams once daily, it's gradually increased to a standard maintenance dose of 30 milligrams twice daily, except for patients with severe renal impairment, who should take 30 milligrams once daily. Side effects often include gastrointestinal issues like diarrhea, nausea, and vomiting, especially in the initial 2 weeks, in addition to weight loss and the possibility of depression or suicidal thoughts, though these are less common. Care is needed when using apremilast alongside strong cytochrome P450 inducers and monitoring in patients with severe renal impairment. Tofacitinib, an oral Janus kinase or JAK inhibitor, is not yet approved for psoriasis, although it is approved for psoriatic arthritis. It offers a potential treatment option for moderate to severe cases by interrupting inflammatory cytokine signaling. While it has a recommended dose of 5 milligrams twice daily, caution is advised due to side effects such as nasopharyngitis, serious infections, lymphoma, and an elevated risk of blood clots. It necessitates regular monitoring for infectious diseases like tuberculosis, hepatitis, and HIV, as well as bone marrow suppression through routine CBC and absolute neutrophil count tests. Adjustments in dosage are essential for patients with renal or hepatic dysfunction, and being that it is a CYP3A4 substrate, tofacitinib requires careful management of potential drug-drug interactions. In conclusion, these pharmacologic options offer diverse approaches to managing psoriasis, each with its own benefits and considerations. As I mentioned earlier, it's critical to note that treatment of psoriasis also extends to biologic agents as well, and each of those medications have their own place in therapy for psoriasis as well. Thanks for watching this video on the treatment of psoriasis with systemic non-biologic medications. For more information and treatment-specific guidelines, you can check out the American Academy of Dermatology.